Daniel Gallego-Pérez, MD, DRPH, is currently a postdoctoral fellow in research at the Program on Integrative Medicine at the University of North Carolina, Chapel Hill. His research focuses on primary healthcare, health system strengthening, evidence and information synthesis and dissemination, and therapeutic pluralism. After graduating from medical school, he served as a primary care physician and public health practitioner in a protracted refugee setting in Ghana, West Africa, for almost half a decade. After returning to Colombia, his native country, he designed and implemented a pilot project to develop complementary medicine services in public hospitals between 2009 and 2013. He has been a consultant for the Pan American Health Organization, World Health Organization, first in Nicaragua, later at the PAHO headquarters in Washington, D.C., and at the Latin American and Caribbean Center for Health Sciences Information in Sao Paulo, Brazil. He co-founded, turning off my phone, the T&CM Americas Network and the Virtual Health Library on T&CM. He's the immediate past chair of the Integrative, Complementary and Traditional Health Practices section of the American Public Health Association, and a visiting fellow of the Australian Research Centre for Complementary and Integrative Medicine at the University of Technology in Sydney. So thank you for being here, and go ahead.
Thank you very much, Ariana, for the invitation, and thank you all for being here, and to the UCSF Osher Center colleagues for this space. I'm going to share my presentation. Okay. Let me know if you are seeing it now.
Looks great.
All right, thank you. Let's get started then. Thank you for the introduction and again for the opportunity of being here. This presentation, the story behind this presentation, the context starts actually it has a long history because the indigenous peoples to this region have been here for more than between 30 to 15,000 years. So the story starts with them and with the culture that they developed on this land. And as a way of land acknowledgement, I would like to play this quick animation that is rather a silent and graphical land acknowledgement. Okay. So by the arrival of Europeans around 1492, the estimated population of Native Americans in the continent were about 60.5 million people. And what ensued after is what has been labeled as the Great Dying of the indigenous peoples of the Americas, where about 95% of Native Americans died during the course of the following 100 years, and that great dying was caused by the mass spread of new infectious diseases, the disruption of trade routes and traditional food systems, massacres, persecution, and displacement. And after that great dying of the first 100 years, what ensued were 4 centuries of one of the greatest genocides that humanity has ever experienced. So We will be talking a little bit today about the context of therapeutic pluralism and ethic and equity perspectives from the region. But the first thing we need to acknowledge is that when we refer often, or we refer most commonly about this region as being Latin, and by virtue of that, that notion often leaves at the margins a great number of people that live there, that live here, including those the original land owners. So in Latin America, there's much more than Latin languages. That notion of Latin was actually a colonial. Many don't have time to go over that context, but we need to acknowledge that in this region, more than 500 indigenous languages are spoken. And of course, we also need to acknowledge that one of the most important component of the social fabric of this region came transplanted through slavery, and slaves also brought their healing traditions and their languages, and that became a very important component of this region. So frequently, Latin America is frequently referred to as a Via Yala, is a concept of the Kuna people in the territories that are more or less at the center of the continent, in the border between Colombia and Panama. That means the land on full maturity of the land of vital blood. The territory is composed by about 40 sovereign countries, and about 13% of the Earth's land surface, and about 8.5% of the world population. And in these territories harbor about 50 million indigenous people and about 200 million Afro-descendants. And it's important also to acknowledge that about 55 million people live in other places of the world that were originally from the region. It's highly diverse and multicultural, interracial, and multi-ethnic. So getting into the topic, it's important to acknowledge that the interplay between the three main components, cultural components of this region, which are the Native Americans and indigenous peoples, the colonizers from Europe, and the transplanted African slaves, created and each one with their own healing arts and culture, created some sort of a cultural interplay and a medical mestizaje, which is evident in the porous boundaries between systems and both professional and lay interpretations of the causes of diseases and the interventions to promote health and healing in Latin America. This interplay and boundary crossing created a unique cultural atmosphere where new practices and practitioners, lay and professional alike, emerge. Healing, religion, magic, and nature have been intimately intertwined in this mestizaje. And that interplay continues today with added complexities brought by the introduction and the emergence of additional healing systems for the migration waves from other world regions such as Asia and later the globalization phenomenon. The interplay between healing systems, however, has been asymmetric and continues to be. The relative importance of each of these healing systems and the social role were shaped initially by the colonial social order and later by many forces. Some of those forces include the formation of the states, the consolidation of political, social, and economic systems that cemented social inequities, and including the secularization and urbanization of the Latin American societies that occurred during the 19th and 20th century, the absorption of biomedicine, scientific research, and technological evolution that dramatically improved the efficacy of medical interventions available through health systems. Despite these asymmetries, subjugated medical cultures in Latin America continue to coexist, evolve, and thrive. Early in colonial times, the colonizers valued the indigenous people's healing arts, often relying on them for healing. Their knowledge, or rather the European reinterpretation of their knowledge, particularly the use of medicinal plants, impacted the medical practice of the time. The healing arts of African slaves and their descendants were essential also in restoring the enslaved workforce's ill health, and the colonizers also utilized them. The colonizers approached these systems instrumentally, however, from an Eurocentric frame of perspective to advance the colonial enterprise. These indigenous and African systems of healing also play essential roles in the social resistance of the oppressed. Despite their relative tolerance toward the systems during the colonial era, concurrent persecution was often associated with the religious and magical aspects, and later with the subjugation derived from the medical hierarchy. The colonial and early post-colonial medical marketplace was very diverse, but gradually competition among practitioners resulted in a medical hierarchy that placed biomedicine at top. That medical hierarchy mirrored the racialized colonial social order. Only Europeans or their descendants who control education of the medical licensing authorities of the time were allowed to enroll in medical schools. Physicians, by virtue of their social status, often dominated the political landscape in the post-colonial period and reproduced much of the colonial social order in the newly created republics. And this social order will mostly remain untouched until the end of the 20th century, so until very recently, when repressed social forces and subjugated healing systems found new channels of manifestation. At the turn of the 20th century, several indigenous movements emerged, and there was a significant mobilization of indigenous movements that have been occurring for the last 400 years, but the presence of the component of indigenous peoples and Afro-descendants in the post-colonial societies were often referred to as the indigenous problem. This notion symbolized the many conundrums of post-colonial societies that inherited a racialized social order built in the dehumanization of indigenous peoples and Afro-descendants, marginalizing their culture. Afro-descendants and indigenous people were at the bottom of the exploited classes, and their cultures were seen as an obstacle for countries' development. Yet, indigenous people in many of these young republics represented the majority of the population and were thus seen as a problem of great magnitude. The first half of the 20th century saw the birth of several indigenous movements across Latin America, which added pressure to confront the indigenous problem. And in 1938, the 8th International Conference of American States called for the creation of an Inter-American Indian Congress that created the Inter-American Indian Institute that became a body of the Organization of American States, which promoted a series of indigenous policies, initially with the aim of being integrationist, seeking to resolve the indigenous problem through assimilation to the mestizo population and the wider culture. But despite the integrationist push, indigenous people continued to mobilize in the second half of the 20th century. Landmark achievements included the 1965 United Nations International Convention on the Elimination of All Forms of Racial Discrimination and the 89 International Labor Organization Convention 169 on indigenous and tribal people. And these landmark agreements paved the way for the emergence of multiculturalism and interculturalism that we saw emerging in the 1990s, along to the development of to the emergence of the notion development with identity that ushered a new era during this time. But it was not until the 1990s, coinciding with the end of the Cold War, that and the commemoration of the 500th anniversary of the arrival of Europeans to the Americas, that significant social changes started to occur. In 1993, the United Nations launched the International Year of the World Indigenous Peoples, followed by the first International Decade of the World Indigenous People. And that year, PAHO, WHO, launched the Health of Indigenous People Initiative, which catalyzed attention given to traditional indigenous healing systems in Latin America, and by extension, to other non-biomedical healing systems known as alternative or complementary. So we really need to thank the indigenous peoples movement for the development and the attention that complementary systems of medicine started to receive on the official and within health systems and within the international health system as well. And also during that decade, Afro-descendants in Latin America also experienced a political down, and they organized and they sought recognition as a transnational community, sharing an ethnic and cultural heritage, and they also got significant gains in the international system. So, but the Latin American social and cultural amalgam has created a fertile ground for welcoming also old and new therapeutic systems from all over the world, and for the emergence of local non-biomedical therapies and therapeutic systems developed in Europe and the United States, such as homeopathy, naturopathy, anthroposophic medicine, osteopathy, chiropractic, neurotherapy, and others, have been introduced to Latin America unevenly, but widely. Homeopathy, for example, arrived in the region in the 19th century, early after its introduction in Europe, and significantly prospered in many countries. Traditional Chinese medicine and Asian traditional systems of medicine initially arrived in Latin America through immigration in the 19th century as well. However, in-country training and widespread use of these systems and the recognition did not occur until the second half of the 20th century, coinciding with the establishment of cultural exchanges and training of Latin American professionals and clinicians. Okay. Yeah. And more recently, also new therapies have been, and there has been also innovation in this field in Latin America, including, as an example, the development of integrative community therapy and or Sintergetica. Community integrative therapy was developed in Brazil, Sintergetica in Colombia. That is basically a proposal for a form of perspective of how an integrative medicine model could be developed. Okay. And there have been also research in other approaches, such as the use of therapeutic use of seawater, among others. So Latin America is one of the most unequal societies in the world, one of the most unequal regions, and there are substantial differences between country and within country inequities, and mostly related, of course, with the distribution of wealth. There has been shown how it has already been shown how the differences in wealth distribution among geographic areas impact life expectancy, for example. But most significantly, the health inequities are much more evident when we compare indigenous people with the rest of the Latin American components of the general society. So the central question we have to this topic is whether traditional complementary and integrative medicine could contribute to health equity, particularly in the Latin American region. And one of the questions we need to ask ourselves, and based on this history that was going through, and is the exclusion of traditional indigenous or Afro-descendant medicine from national health systems is a sign of social inequities, and probably the answer is yes. And the Lancet Commission in 2014 gave us some clues where it affirmed that the systematic neglect of culture in health is the single biggest barrier to advancement of the highest attainable standard of health worldwide, and warned us that we need to acknowledge the cultural basis of biomedicine itself and incorporate the relevance of culture in care pathways and decision making in healthcare systems. And it also advanced very powerful ideas regarding that the notion that biomedicine is able to address the ills of the world and all societies is fundamentally a cultural notion. So other questions we need to ask ourselves regarding the issue regarding health equity in traditional and complementary medicine is whether the inclusion of these systems within health systems, of these healing systems within national health systems could contribute to address inequities, and that's a question for which we still don't have concrete answers, but our intuition is that yes, it could contribute to address health equity. And other questions that we need to ask ourselves is whether that there are several initiatives in Latin America, whether these are being successful, and whether T&CM is being used to fulfilling biomedical services access gaps, or whether equity considerations are being included in T&CM development across the region. And other equity consideration has to be with the international system, where the use of some elements of traditional healing systems, such as coca leaves, and continue to be marginalized and demonized in the international system and deemed illegal, and also it's important to acknowledge how traditional systems also have traditional uses for plants, such as tobacco, and there are significant equity considerations when it comes to the use of those plants in larger societies. So T&CM systems are used all over the world, and there's several international frameworks that call for the integration in national health systems, and those frameworks of integration across countries have been growing significantly. But in the Americas region, we trail behind many other regions when it comes to the development of those national frameworks that make possible that work on integrating these systems within national healthcare systems. And so part of the work I did with my dissertation was to try to understand the landscape of what was happening with the policies and these frameworks for integrating traditional and complementary medicine in healthcare systems in Latin American countries. So one of the first things we wanted to assess is trying to understand which policy mechanisms are developed, are used to enact these kinds of policies across Latin America. And we were able to identify that 4 countries include the recognition of traditional and complementary medicine within their national constitution, within the political constitution, and countries across Latin America use a diverse approach within the hierarchy of the law to bring these policies forward, including statutory law, national policies, the development of healthcare models and national program guidelines, and a diverse host of norms and regulation for the practice of these systems. And this level of political commitment we are seeing for the integration of traditional and complementary medicine is a reflection on the changes that we have been seeing in the political landscape, particularly since the 1990s, as I was earlier explaining. And that wave of change brought forward by indigenous movement and has also made possible new social contracts that basically have changed how states identify themselves and how and they have shaped the national identity, where constitutions are starting to uptake traditional indigenous concepts as a way of framing their way of life and their cultural identity with notions such as summa causae or good living. And of course, this transformation has brought then many changes in trying to restructure healthcare systems that accommodate for those perspectives and concepts from traditional indigenous systems. And some of these laws have really embraced those notions. There have been a diversity of orientations of how national healthcare systems and countries have framed and conceptualized and approached the development of policies on this field for integrating these healing systems into national healthcare systems, and some. And here we have a description of some of those models that include health services center, a model of care-based, participatory, or indigenous people's health focus policies. So the most frequent type of policy or the way the WHO has framed the development of these policies is basically utilizing this first approach that we found, which is health services center that focus on the articulation of traditional and complementary medicine to government-run healthcare services. But there are other approaches that have included the transformation, the complete transformation of national healthcare systems through a new definition of what the care model of the country is, that incorporate intercultural health perspectives and approach to integrate therapeutic pluralism in health systems reform. So part of there's a coming paper on the therapeutic pluralism policy process in Latin America. But one of the main problems we have is that there's not enough research happening in the region to document the different components of the policy cycle. But we know that there are problems in the way that these policies are being formulated, and there are problems in the way these policies are being implemented, and of course there are several shortcomings of them as well, and we really need to advance in developing research because it's highly insufficient. And as part of the approach to try to provide a framework on which countries can use to update or develop new policies on this field. Part of my work in the dissertation research that I did was to develop or describe the key therapeutic pluralism policy elements that these countries need to consider when developing such policies. And in that process, I also developed a technical cooperation tool that could guide health officers in the process of doing a national situation analysis and identifying policy gaps, and then proposing policy mechanisms to address those gaps, and developing, of course, proper monitoring and evaluation proposals for these policy approaches. The tool that was validated through a Delphi process, and will also be soon available in a publication. Of course, it has limitations, the tool, and we're planning to field test it. It is only a theoretical framework and tool at this point, but we're in the process of trying to field test it in the upcoming months. I also wanted to highlight that one of the approaches that we have done in the region for advancing equity is the creation of tools that could enhance the access to information on traditional, complementary, and integrative medicine. And as such, in 2017, we organized a regional meeting of 21 countries where a regional network for traditional and complementary medicine was created. And that network made possible the development of a virtual health library on T&CM with specific mechanisms of collaboration and development of content. And this is a web portal that we aspire that it becomes a one-stop place where stakeholders in the region can find all the information they need to advance practice and decision making also within national healthcare systems. So in the paper that is on the slide, you will have a full description of the different sections and components of that online tool that includes a database, access to multiple databases, and a database that we develop for the region as such. Through that network, we also have been developing collaborative information products that include the development of evidence maps on the on the field that are available on the virtual health library website and other information products, including online event series and other approaches such as windows of knowledge that is proposed by our PAHO Health Information Sciences Center in Brazil. The virtual health library has been online since 2018, and it has been visited from people from all over the world. And so to end, I would like just to highlight that although there are solid international mandates for the development of therapeutic pluralism policies, the evolution of frameworks to support policy development has trailed, and despite progress, countries continue facing challenges for developing adequate policy responses in the vast and complex field of therapeutic pluralism. But we believe that characterizing the policy approaches and mechanisms within regions is important, so that a global framework could also respond to the different approaches, because current frameworks have mostly been developed with the assumption that integration only happens at the service provision end. But as we saw in the description, the integration of these approaches are also informing how healthcare systems are conceptualized and organized. And as I highlighted, policy research on therapeutic pluralism in Latin America is insufficient. We still have not enough information to answer equity questions, but we need to keep advancing on this research agenda. And but we believe that this methodological approach that was proposed during the work I did in the dissertation could be used for characterizing other therapeutic pluralism policies in other world regions. And we recently learned through a colleague, Nadine Jazz, that an initial seed grant for advancing this work in other world regions have been awarded. So we're very hopeful that we could move forward with this work in other world regions. I wanted to play a quick clip here that highlights the importance of integrating culture in healthcare systems.
Si en la península de Yucatán la costumbre generalizada es el uso de la hamaca, ¿por qué no poner hamacas dentro de un hospital? Es romper con esa estructura vertical dominante de poder en que quien establece cómo deben ser los hospitales son los médicos.
Dice, yo quiero que me den de alta porque ya no aguanto esta cama.
La cama me está viendo caerme, porque están muy angostas las camas. En la hamaca bien que me puedo virar como yo quiera.
Me sentía feliz de que los doctores se hayan preocupado por sus pacientes. Pude acomodarme bien con mi bebé. Ya no tuve el temor de soltarle que se me caiga.
Habemos personal de salud que estamos a favor de que las instituciones hospitalarias sean más democráticas, es decir, que exista la palabra de los ciudadanos en cuanto a sus derechos y en cuanto a las formas en que deben de ser tratados.
Okay, so there are examples in the region also where hospitals are being developed using the culture, the local, in collaboration with the local communities, so that the systems adapt to the way people live, not the other way around. That is how often we assume healthcare systems are to be developed. So if you wish to learn more about Latin America, I invite you to explore its rich musical culture. I have another clip, but we have no time now to play it. So thank you very much. I wanted to acknowledge also the work of the collaborators from the T&CM Americas Network and our Center of Health Sciences Information in Sao Paulo that have made a lot of this work possible. So thank you very much. And Ariana, your microphone is muted.
Sorry, thank you. I was thanking you and saying thanks for ending right on time so that we have a bunch of time for Q&A and discussion. I think since we're not a huge group, that if people have questions and want to come on camera and ask them, you can feel free to do that or put questions in the chat as well. I'm going to start with a question from me, which is, I'm curious, it was so useful to hear this really broad overview of what different national health policies look like. And I'm curious if you could share an example of one that you think is an exemplar or a relatively positive example of what a more equitable intercultural version of T&CM policy can look like.
Yeah, there are different examples for the different kinds of approaches of formulating national policies. For example, in the health systems, health services centered approach, a good example is the work that Cuba has done. Cuba has set up a national policy for traditional and complementary medicine, where they have made available interventions of these approaches in all levels of care at the national level, and they have done it through channeling and training the workforce and making available these services from starting from neighborhood consulting rooms and through the primary care network and secondary and tertiary level of care. Approaches such as health system model of care transformation, an example could be that of Bolivia, which developed a model called I'm forgetting the full name in English, but it would be something like a health model of family, community, and intercultural health, which basically is trying to change the notion of how the entire health system is conceptualized as such, and bringing within the within the conception of the system and within the approaches, not only to providing services but also organizing and thinking what the system is, bringing notions of traditional knowledge and traditional wisdom, and including also traditional indigenous practitioners within the scope of the services as well. Policies like a participatory approach to policy development, for example, a good example is the Brazilian national policy for the integration of what they call complementary and integrative health practices, which was developed from, you could say, from the bottom up, including different stakeholders to come up with a proposal that was multi-professional and the most inclusive approach possible into trying to bring these systems within the scope of the unified health system that they have in Brazil. There's some examples.
Can I ask you a quick follow-up question about Cuba? And then I have some other questions from other people. So Cuba, which has a very universally accessible but top-down system, are they primarily training physicians and nurses in T&CM, or are there other training pathways to, say, become an acupuncturist or whatever?
One of the most interesting features of the workforce training models is that they have included T&CM training modules in the training of all health professions. So is across the board. So all health professions get different training, different modalities in the course of their professional training, and they have developed also a very robust postgraduate system that include master's degree for different multi-professional master's degree to allow different professions to further clinical skills and research skills on the field. And they also have, and it's perhaps the only country in Latin America that has a residency program on T&CM. So they have a full residency program that is 3-4 years long, and where the T&CM residents take guards in emergency rooms, and they serve inpatients and outpatients, and is a residency, a hospital-based residency training. So they, through that model, they have been able to expand in the different levels of care of the system, because of course these specialized physicians are also mostly located in high-level hospitals. High level of care.
That's so interesting. Thanks for sharing that. So other questions. Jen Felder says, this video you ended with was such a powerful example of how institutions can adapt to the people and ways that this can have a powerful impact on satisfaction with healthcare. Do you have other concrete examples of ways that institutions have adapted to people instead of vice versa?
Yeah, so the picture I show with the hospital that had like this domes and so on. In Chile, there have been an effort to develop intercultural hospitals and intercultural health centers, where they design like from the stages such as where the hospital needs to be located, where the windows need to be facing, whether they need to face to the north or to the east, and where the door has to be located based on the local customs and the traditional beliefs of the local communities, and the development of also functional structures within the hospital, and how patients, what is the flow, the patient flow within the hospital. The definition of those processes are developed in collaboration with the community, and also including how the community accesses the different kinds of services, including the availability of local healers through health services. So that's an example in Chile, but there are other similar examples of efforts of creating intercultural health services in Mexico, Bolivia, and other countries. And in Colombia, there's also currently an effort to develop basically a parallel healthcare system focused on to serve indigenous people, where basically they are developing a national framework that will allow each community to develop in collaboration with the health ministry the care model they need based on their own traditional practices and knowledge, and these models will take a central core of the development of these care models for each of these communities is their own medicine and their own culture. There are many examples across the region, but one of the most significant challenges is that there's not enough information about the design as such, and there's not enough research about how these policies and models are being designed, and how successful the implementation is, and what kind of impact these initiatives are taking. There's simply not enough research, and many of these initiatives are developed without the inclusion of indicators that could allow the monitoring of the impact, or with structures that could make possible systematic evaluation of the impact on the law.
That maybe sets us up well for the next question, which is, can you share about where you see your research going in the next 5 or 10 years? Or kind of what are the next steps of this work for you?
It's a difficult question. Because I still don't know. One very concrete step that is already happening is that we want to replicate this level of analysis and to trying to understand the policy mechanisms and the policy orientations and characteristics on other world regions. Basically, we think that it's important to try to figure out where world regions are in terms of the approaches of how the countries are developing these policies, because basically the WHO has told countries, develop policies that integrate these healing systems into national healthcare systems and services, which are without much guidance. And as I mentioned, the focus has mostly been on the integration at the service, on health services integration. But these other approaches that we saw in Latin America, such as efforts to transform how the entire healthcare system is conceived and organized, and not only impact integration of services, but also how public health programs are developed, and the approaches need to be taken into consideration when global frameworks are being developed. And the WHO traditional medicine strategy is ending, and a new strategy needs to be developed starting this year, and it will be under development for the next 2 years. And this kind of knowing these different approaches would be useful so that the international frameworks could take into account those policy orientations. So one significant line of work will be trying to replicate this work in other regions, and we're going to do, starting with Africa. We already have a seed grant that was awarded just yesterday to do a similar work in the African region. We're reaching out to researchers in other world regions to do similar work. And another line would be to do research to try to answer those equity questions I was mentioning, because they are mostly questions now. We have not enough information to ask them, but that would likely be another line of work, and as well as apply policy research in different countries and assisting in the development and updating of national policies.
Thank you so much. I thought we might have time for one more question, but I think we need to let people go. So really appreciate you coming and speaking to us from afar, and thanks everyone for being here today.